Good morning, everyone. Always a delight to meet you all with another academic session. First of all, let me direct your attention to this slide. So this is the National CPD program, and it has the link to register as a CPD mentee and a video guiding you how to register. So what we expect is for you all to go through the video and register as a CPD mentee, and once you upload at least one CPD certificate to this, you will get a registration number, and then the continuation will be done with, for the next year as well. So before the 31st of December, you have to register, and please be kind enough to do the needful in regard to that. And today we are bringing to you all a very interesting topic: wound management, understanding basics to improve patient outcome. Our resource person is Dr. Manujaya Godakandage, consultant vascular and transplant surgeon, teaching hospital Anuradhapura. Dr. Manujaya got his MBBS from University of Colombo 2012 and completed his MD in 2019 and got his MRCS in 2021 Glasg. Had his fellowship at Royal Free Hospital London and University College of London. He's had multiple publications in local and international forums. And we are thrilled to have such an academic with exposure to the latest wound care management guidelines. So without delay, let me welcome you, sir, to conduct the lecture. Thank you.
Thank you, Ranesh, for that kind introduction. So today we are going to discuss on this wound management. I said that we'll go through the understanding basics to improve patient outcomes. So briefly, what I'm going to touch upon in this brief period of 1 hour is I'll be touching on wound basics, the types of wounds and how to identify them, when to refer them, dressings, at least a short overview of what is there, and the practical approach. I'm sure that would be the most important part for you, and what the rest of the world is doing and what we can learn from them, and ultimately our most important thing, how to improve the patient outcomes. So a little bit of caution, I will be using some wounds and surgical procedures, photos of them. So if you are a sensitive person, just bear in mind you may need to have some discretion. Okay, so let's go on to the topic. So wound basics. What do you mean by the basics? Okay, so first of all, let's start with identifying what is a wound or an ulcer. There are many definitions from different point of view. So basically, a wound or an ulcer is a disruption in the integrity of the skin, mucous membrane, or an organ tissue. When explained pathologically, it's a local defect, excavation, or of the surface of an organ or a tissue caused by a sloughing of the inflamed necrotic tissue. So you can see there are several processes going on: injury, inflammation, impaired repair, something in that sense. So in more simple way, we can say that it's a breach in the continuity of the epithelium or endothelium or a organ tissue. Okay, so that's the first thing. So do you guys know what's the difference between a wound or ulcer? So if we go back to the literature and the classical descriptions, wound means when there's an injury occurring from the outside and there's a defect in the continuity of the epithelium, so that's a wound. So the injurious factor is coming from the outside, versus if it's an ulcer, it's classically described as coming from the inside or from the patient him or herself. But nowadays it's sometimes very loosely used. So wound, ulcer, whatever you need to know is that there's a defect in the epithelium or the endothelium. Okay, go into some theoretical stuff. So when there's an injury, what happens in our body? So first of all, when there's an injury, it's going to be a bleeding. There's going to be some bleeding resulting in clot formation, that is called hemostasis, and then this goes into the inflammatory process inflammation. And then with the inflammation, what happens is there's a lot of cells, humoral factors, and various cytokines and everything coming in and trying to elicit a inflammatory reaction, so that whatever the injurious agent is controlled, and injury is controlled, and the repair is going on. Then it goes into a proliferative stage, the stage 3, where there's a new vessel formation, fibroblasts form, and then epithelium is trying to rebuild itself. And the ultimate stage, or the stage 4, is the remodeling, where the collagen is deposited and it's remodeled to come to at least to the normal state, trying to come back to the normal status. But however much they try, we know that it cannot become 100% as normal, but they are trying their best. So in summary, when there's an injury, basically we can say there are two things that can happen. If it's a superficial mild injury, the epithelium will regenerate and will come almost back to the normal status with minimal disruption or no disruption at all. But if there's a severe injury, what happens is the inflammatory process and the proliferation, and this process is so huge that it's unable to bring back the tissue to the normal level, and they do their best and there's a scar formation. So let's move on to the wounds now. So almost everything has a classification. So how about the wounds? Well, when we talk about wounds, there are many classifications. There's no one model that fits all. So when it comes to surgical wounds, we can describe them according to the cleanliness of the surgery, like clean, contaminated, and dirty, and depending on the healing time, and according to the etiology, and sometimes depending on the particular ulcer, there are various classifications. For example, for diabetic foot ulcers, there are various classifications, including Texas classifications. But to our day-to-day practice, what should we do? So should we use these classifications or should we not? Well, I would say when it comes to our routine practice, when we are more clinically oriented, this is what really matters, or probably this is the most relevant thing. So the time to heal, depending on that, we have acute wounds, generally considered as less than 4 weeks in the literature, and the chronic wounds, which take about at least 4 to 12 weeks or more than that. And the other thing is wounds. All the wounds we can divide into simple traumatic wounds and the non-traumatic wounds. Bear in mind, when we talk about these non-traumatic wounds, sometimes the patient may say that, okay, doctor, this started like this. There was a small trauma to my foot. Some stick hit my foot. Then all this started. So even though it sounds like traumatic, if we analyze it truly, it's a non-traumatic thing that keeps the wound going. So in that case, it would be more appropriate to consider it as a non-traumatic wound, even though there is a precipitating factor. Okay, so this is why we are here. So if everything goes perfect, if the wounds heal perfectly, there's no need to bother about the wounds. But things does not go as we expect, and that's why we doctors or surgeons or general practitioners have to intervene. So this is where it can go wrong. There are local factors or systemic factors that impair the wound healing. So overall, we can take it as the things that are near the wound that impair the wound healing, or else the things surrounding the wound that impair the healing, or else the generalized factors in the patient that impair the healing. If we become more theoretical, we can divide it into local and systemic. Local, if there's ongoing infection, if there are concerns about the blood supply, if there's congestion, venous congestion or lymphatic congestion, or else if there's too much tension or too much pressure or too much movement at the site of the wound, it's not going to be helpful. If there are foreign bodies, if there's ongoing malignancy, or else if it's too dry or too wet, it's going to be impaired. Moving on to what impairs in the systemic component or else in the patient as a whole, age. The elderly, it tends to become more protracted. And smokers, many things go on and the healing is impaired. Obesity, same thing happens. Diabetes, it's a multifactorial thing where the wound healing is impaired, which I will briefly touch upon in the subsequent slides. Malnutrition, yes, as we all know from our medical student days, nutritional deficiencies, vitamins, minerals, when they are deficient, yes. Connective tissue disorders, yes, patients with like antiphospholipid syndromes, SLEs, vasculitis, overlap syndromes, they have problems with healing their wound. So that's it. Okay, so it's not easy to talk only about theory, so we need to move on to the patient. So let's talk about the patient. All right, so when a patient comes to you with a wound, what goes through your mind? So obviously it's a wound, so you know that. Then we have to see what is causing this wound, how we can help the patient, and how we can heal the wound. All right, so let's start with the history from the basics. So first, when it started and how long it has been going on, and the associated symptoms, whether there's pain, discharge, and most importantly whether how this wound is affecting the patient, right? Like whether the patient is having fever, feeling unwell, loss of appetite, in other words meaning that whether this patient is in sepsis, or else it may be very subtle differences in the elderly patients, like geriatric population especially. They may have very subtle differences, like in 80s, 90s, sometimes they may feel not feeling quite right, or else the appetite is reduced with a wound. So they might not have the florid infection signs like gross infection signs like fever, significant pus discharge or anything, but still they may be quite unwell. So it's quite important to detect those patients as well, because if you see most of these chronic ulcers present in this elderly population, then the progression, how it has progressed, whether there are any other similar ulcers, what was done to the patient previously, what he or she has had done, any other comorbidities where we can address, or whether they are having any effect on the wounds, and the smoking, most importantly. Okay, let's have a look at some wounds. Okay, so what can we gain from this wound? So first of all, we have to see where it is, the site, size, rough idea, whether it's a small one, large one, what is the extent, the shape, and the margins, how the margins are. As in this one, it's clearly clear margin with a very superficial ulcer, and the base there is some sloughy tissues, no significant granulation as such. And most importantly, always check the pulse. Whatever the wound is, always remember to check the pulses. This one may look like a venous ulcer, but there may be a component of ischemia as well going on, looking at the appearance. So always remember to check the pulses. If you take home one message from this today's activity, I would say remember to check the pulses. Okay, so let's move on to some of the classical wounds and how to identify them, because the patient does not say that this is this type of a wound, but it's important for us to identify so that we can do whatever needed. So ischemic ulcers, as you all know, usually occur in the periphery, pale, black, pale, like in this one, or it may be a florid gangrene, dry gangrene, or dry gangrene with a wet margin with some evidence of infection, and they will not have the distal pulses, palpable ones, and usually they are painful unless hugely neuropathic. Still, even in the neuropathic, most of the time they have at least some sort of pain, ischemic pain. So what we can do, if it's ischemic, we need revascularization. Amputation is an option, but it's not always a below knee or above knee. As in this one, the big toe has been already removed because there was gross infection on top of ischemia. So it's still an option, but let's go through what we can do before offering a major amputation, because the ultimate intention is not to amputate but to heal. Okay, this is what we can do. We have open surgery, we offer bypass. This is a bypass with a vein. So this patient came with a wound in the big toe, and what we did was exactly this was yesterday. We did a bypass from the popliteal artery going on to the posterior tibial, almost near the ankle level, or I would say slightly below the ankle level. And this is another one where we did a bypass with a graft. So we are ensuring that there's adequate blood supply to the area of the wound. So when the patient comes like this, remember, we can do something. So patient needs to have some specialized care. So this is what we do. This patient did not have any pulses, no dorsalis pedis, no posterior tibial. So this is what we did. If you can see, this is the posterior tibial. So there you can see there's a obvious pulsation after the surgery. I'm sure this must be interesting for you guys, because this is what we really do, and we rarely see it, what is done. Okay, so is it always a large cut? No, we have other options in the toolbox as well. This is angioplasty, which most of the centers with vascular surgical expertise are able to do in Sri Lanka. Minimally invasive, I would say it's the equivalent of a laparoscopy in general surgery. Minimal incisions, or rather no incisions at all, percutaneous access. And so you can see with this angiogram done on theatre table or angiographic suit, this patient has a block here in the simplest words, and there's no significant blood flow to the foot. This is actually a 72-year-old male patient who came with ulcer in the toe areas. So this is what we did. We did angioplasty, or if we go into what we did, we put some wires down, we went through this area, we put some balloons here, and ultimately we opened up. Right. There are various devices, various techniques, various things available. We can open up this without a large cut. So this is the blood supply after this. So there is hope. If you go back, for this one, we have plenty of options. Okay, that's all for the arterial. So let's move on to the venous, one of the common wounds we see day-to-day practice. And patients live with them for years and years and years. Sometimes, as we all know, patients earn from them. That's another thing. But we'll focus on healing them, not to keep them, right? So venous ulcers, as we know, over the medial malleolus or the lateral malleolus, as in this middle one, you can see extensive ulcers with skin changes, this whitish skin, and the pigmentation is gone with blackish discoloration over here, and also this one. So usually it's a long-standing or a recurrent ulcer with itching, they may have some discomfort slash pain, aching type, and usually at the medial or lateral malleolar region. Typically, it's a superficial ulcer with evidence of skin changes like pigmentation, lipodermatosclerosis, evidence of gross varicose veins. Sometimes we may not see the gross varicose veins, but if we do a duplex scan or ultrasound duplex scan, there will be refluxing veins, and it's the root cause for these ulcers. So what we can do, the most important thing, so we can treat them. Traditionally, we used to do saphenofemoral ligation and stripping with some cuts and some surgery, groin incisions. But nowadays the world have moved forward. We have not completely abandoned SFL and stripping. Still there is a place, I agree. General surgeons are doing a great job with this SFL and stripping. Otherwise,
Yes.
we can't deal with all these patients. They are doing a marvelous job. Still, we have other options. Laser, as we all know. Foam sclerotherapy. This is the thing we have been doing for many years now. Not the plain sclerotherapy mixed with air. And also the good old multiple step avulsions, they are also there. Alright. And whatever we do, compression therapy is there to stay with good quality evidence. When it comes to venous ulcers, the most important take home message is do not wait till the wound heals. We have to intervene even with the wound because it reduces the time of the wound and it speeds up the healing, and there is nothing like we should wait for the wound to heal. And there's good quality evidence, level 1 evidence or randomized control trial evidence to say that treating the varicose veins or the venous hypertension or the refluxes in the veins in patients with venous ulcers is beneficial and reduces the time for healing. Okay, so coming to the practical part, this is what we do. This is laser therapy, or the full term is endovascular laser ablation. This is a patient coming with varicose veins with the ulcer. Unfortunately, we don't have a view of the ulcer here. And this is, we have inserted the laser fiber, so it's minimally invasive. It's only this cut, which is about maybe maximum 3 millimeters. The laser fiber in, this is a light, and what we do is we burn the vein from inside from all the way up to here. So this is more diagrammatic view what is done. So this vein becomes like this at the end. Some photos of the appearance, but more than the appearance, we are concerned about the wound healing in these patients. Phlebectomy or else multiple stab avulsions. There's no need to be afraid. There are no major cuts. If done properly, it's going to be a 2 millimeter cut. Rather than a cut, I would say it's a stab. Means a nick, in other words. So it's going to heal within 2 to 3 days. By the time we open up the dressing, there are no wounds, no stitches. That's what we do. And foam sclerotherapy. So this is how we do it. It's a foam injection, minimally invasive, going into the vein with the ultrasound guidance and treating them. Okay, so we have discussed about the arterial, venous, which are probably the most common, and the next most common, and I would say probably we take a little bit time to identify them and manage them. So this results in a huge burden to our patients and the hospital setup as well. So what do you think about this? It looks like a little bit red here and a little bit pus here probably, and the second toe looks a little bit dusky. So what goes through your mind? Well, to some it may look like the tip of an iceberg. To some, it may look like, well, we can give some antibiotics and see. It's up to you to decide what goes through your mind. And this one also, it's a looks like a chronic ulcer going for some time, and there's a little bit of dark patch here. So it's up to you to think what goes your mind. So these are diabetic foot infections and diabetic foot ulcers. So first let's go through what exactly is happening in the diabetic foot. So everybody talks about diabetic foot. It's a hot topic these days, even in the world. There are forums, there are working groups, there are guidelines, whole lot of interest about this diabetic foot, I would say within the last couple of decades, and which is a hot topic, and there's a lot of industry involved, lot of things going on, lot of inventions, many things. So going back to the basics, so when we talk about diabetic foot, we can't isolate it from neuropathy, vascular insufficiency, infection. I would say these are the main three components. There is sensory neuropathy, motor neuropathy, autonomic neuropathy, and vascular insufficiency, macrovascular, or that means the large vessels below the knee vessels, or in the small vessels like the capillary levels. And infection, they are at increased risk, the immunity is suppressed, and the responses once there is an infection is are reduced. So even a minor trauma can aggravate, or with the background of all these things, can cause a major disaster in a patient. If we go to the definition, it's an infection, ulceration, or destruction of tissues of the foot associated with neuropathy, peripheral arterial disease in the lower extremity of a person with diabetes mellitus. It's a long definition, but in simple terms, when it comes to diabetic foot, it has component of neuropathy, infection, vascular insufficiency to begin with, and this leads to mechanical disruption of the foot. Foot dynamics are altered, and there's a huge mechanism going on there. So these are some photos or rather pictures to show what is going on. So this is, let's go with the first one. So this is ulcer developing from repetitive or excessive trauma. So their feet are deformed due to this ongoing ischemia, neuropathy, and impairment of the small muscle functions, autonomic dysfunction. So this is one deformity, and so this is the metatarsal head of the big toe, and it's hitting on the skin, ultimately leading to an ulcer and causing a huge problem later on. So these are the areas of highest risk. You can see the toes. If you see a foot like this, always think this is most likely to be a diabetic foot, the commonest DD. And the typical appearance of the toes in advanced diabetic foot. So when we go to the history, the patient will always have diabetes or maybe undiagnosed diabetes. They may say, okay, I'm on diet control. Well, if you have a look at their chronic glycemic control, it will be all over the place. They will have pain, and sometimes they may be presenting with systemically unwell, fever, not able to walk, not able to get up, lying on a trolley, lying on a bed with a red hot foot. If you touch the foot, it will be warm, and there will be pus discharge or abscess or necrotic tissue going on. And when it comes to a diabetic foot, sometimes it can be on top of charcoal foot. I'm not going to go deeply into this charcoal foot because it's a topic by its own, but just in the background, remember there's something called charcoal foot that can happen. So how to do a complete diabetic foot examination? The essential components: we have to assess the vascularity, neurology, dermatology, and the musculoskeletal. I'm sure we can read up and go through them. Okay, coming back to this picture. So this is a diabetic foot attack. This is not my words. This is not just imagination. It is an attack, like a heart attack. We all know if it's a heart attack, we have to act fast. It's same with the diabetic foot. If we do not act fast, this one sitting on top of this patient's foot in 2-3 days will extend, can take his limb, can take his life even. It is that bad. So most important thing is identify it as soon as possible. Early detection. This needs urgent debridement, ideally within 6 hours. I know practically it's quite difficult, but we have to do it as soon as possible, right? And most of the time it's difficult to do it at a GP practice, so diabetic foot, I would say the best place to manage is at the hospital, because we have theaters, we have IV antibiotics, we can monitor the patient, everything. And once we do a debridement, proper debridement, clean up everything, drain the pus, everything, it's a must to send a culture and ABST. But before doing everything, we need to start on empirical antibiotics, and once the tissue cultures and ABSTs are available, we can change over the antibiotics, what we call the antibiotic stewardship, a new term to some, but should be a very routine word in the future. And don't forget the patient. This is not only the foot, the patient will have the full-blown sepsis. Even with something little like this, the patient can die. So it's important. And we need to get on top of this glycemic control, insulin, metformins, whatever needed. Probably if it's all over the place, we might need the support from the endocrinology team. And once we manage the acute, or I would say the urgent more stuff, then we need to focus on the proper wound care. We need to offload this one. I will touch upon the offloading later. And as I said, this is not only diabetes, so there's component of neuropathy, vascularity, and everything. So they might need, or they may need, the chances are quite high that they will need some sort of revascularization, like I said, the bypass, angioplasty or something. And once the acute phase is sorted out, we need to follow them out. We can't forget them, we can't let them be. We need to keep an eye on them and make sure that they are safe. Okay, some practical things. So what do you think about this? This is a common presentation. Ulcer going on for years and years. Patient is not too bothered, does not feel anything here. If you take X-ray like this, so what do you think? Should we excise? Should we cut? Should we just leave it? Well, what's going on here is there is fibrous tissue growing around this area, and it compresses the underlying tissue, and as a result what happens is this middle bit is poorly perfused because all the capillary level vessels are compressed. Whenever the patient keeps the foot down, it's compressed, so we need to shave it rather than excising. This is the proper thing to do. Maybe a number 15, number 11 blade, and then carefully shave it like shaving something, right? And make sure there's no bleeding, because we don't need to cause any further damage. And most importantly, we need to repeat it again and again, right, until the wound heals. And subsequently we need to make arrangements for proper footwear so that this pressure is relieved and callosity development, we can prevent it. So there's a preventive component as well. Okay, so what to tell to the patient? So foot care is important. Diabetic patients, no fancy nail cutting like this. It has to be straight and safe. Fancy shoes, yes, but make sure that they are adequately spaced and there's adequate space, not something like this. This is best. In fact, nowadays we have some diabetic foot which are quite good. And daily inspections are important, nail care, appropriate footwear, and early detection of the wounds and at-risk foot, and appropriate treatment in a timely fashion is important. Okay, so we have discussed arterial, venous, diabetic, and now something about pressure sores. It's nothing new, everybody has seen. So usually at pressure points, bed-bound patients, paralysis, starting as a superficial, may go into deep tissues like even to the bone. So we need to get rid of the pressure. If it's near somewhere like a sacrum, we need to think about minimizing the contamination. We need to optimize the patient as a whole, because usually they are quite frail patients, or else patients with the spinal cord issues and impaired mobility. And wound debridement we might have to do, and if there's a need we may have to even consider revascularization, but usually it's not the case. And soft tissue cover. So if it's a very extensive deep one, we need some soft tissue cover, as in the form of flaps, skin grafts, where the plastic colleagues come into our help. But not for each and every one. It has to be selective. Okay, I told that we will go through some offloading. So this is one of the fancy shoes, expensive, available. What we can do at a low cost level is this. This is available, a crepe bandage or a cotton crepe. Make sure there is good padding underneath so that there's no direct contact and there's no injury to this area. Right, so this is a patient with a heel ulcer somewhere here. So whenever he lies down, so it's not pressing on, and this patient is in fact walking with some crutches, so he's not going to place the foot. So yeah, otherwise we need something here as well so that he does not weight bear on the heel. Okay, so those are the common things. So how about this? On and off, these patients will come. Nobody knows what's going on. No clue. People try different things, but nothing happens. It grows. So this is a pyoderma gangrenosum. It's a painful erythematous ulcer with some central necrosis, reddish thing, usually over the shin areas. This is a vasculitic ulcer. Usually they have other comorbidities like connective tissue disorders, and they need multidisciplinary management, involvement of vascular surgeons, immunologists, rheumatologists, whoever that is needed, and rehabilitation as well in some cases. Do not miss these skin cancers. They present as ulcers, basal cell carcinomas with the typical edges appearance, squamous cell carcinomas with flaky lesions, melanomas, not typically ulcers, but still I thought I'll include that as well, Merkel cell carcinomas. Okay, this one, long-standing venous ulcer, squamous cell carcinoma. This will have a typical smell. If you smell it once, you will never forget it. Margarine ulcer. Okay, so how do we feel? So we have gone through the basic types, but always there's more to learn. I'm sure many of you have seen this one, the large sausage-shaped big toe, small ulcer here, and okay, let's forget about this area. So you treat it for some time, do some wound someone has done a debridement and it looks healthy. There's a little bit of reddish area, but still the toe is like this. So somebody decides to do x-ray. So this is what is going on. If you can see, there's gross osteomyelitis going on, and it needs proper debridement, antibiotics, and proper follow-up, so that we can control it. Otherwise, what will happen is it will spread. Ultimately, the whole foot is affected, and patient can no longer walk on it. It will be like, at some point when the patient keeps the foot on the floor, the foot will just break. But if we detect it early, at least at this stage, then we can do. So it needs specialized management, regular follow-up. I would say best manage with a hospital follow-up. Most important thing is detection, because that's where we need to identify them and go for specialized management, and then follow-up can be done. So okay, so when to refer? What does the general practitioner can treat? Does he need to refer everything? No. Does he need to be selective? Yes, I would say yes. The most important thing is identifying what needs to be referred. So I would say arterial ulcers, venous ulcers, that is, if there are no pulses, don't delay. It needs attention, as I showed. Venous ulcers, yes, if there are varicose veins, venous hypertension, it needs further assessment, scans, and treating it. Just the compression is, it's like a temporary thing. In some patients it might heal, but definitely it's going to recur, and it's not going to be a permanent solution. So it needs definitive care. So all arterial and venous ulcers that are not treated properly or appropriately, not treated in the sense I mean the interventions wise, or the underlying etiology is not corrected. If the wound is not healing, let's say even if it looks like a simple ulcer, that can be managed. Like, I'm not disregarding the role of the doctor. They play a very important role. There's a huge respect for them. They are the front line. But if the wound does not show signs of healing, it's not filling up, it's not reducing in size, even we think there is something we have missed. So I think it's being humble about ourselves, that there is something more we can do. So if it is not healing, maybe discuss with someone else, maybe a specialist, maybe a vascular surgeon. I'm saying vascular surgeon because I'm a vascular surgeon, but there are general surgeons also, and other specialists. But there's a whole lot of toolbox we can offer. That's why I'm saying that we can do something more for these patients. So be honest. If it's not healing, always discuss. If uncertain about the assessment and etiology, whenever there's a wound, we have to assess, as I said. But sometimes these atypical ulcers, it's quite difficult to identify and see what's going on. Or else, if unable to provide a follow-up care, then should be referred. Because it's not a single one-off thing, it's a continuous care. So simply, if in doubt about the ulcer and its healing, if it needs specialized management or intervention, without delay, I would suggest to refer these patients. Because you are not saving only the limbs, you are saving the lives as well. Okay, a hot topic, wound dressings. I'm not promoting any brands, but this is some of the things which is available. Expensive, sometimes cheap things also. So wound dressings, what should be there in the wound dressings? So these are the characteristics of ideal wound dressing. So ideal wound dressing, we need to maintain the ideal moisture, prevent infections, prevent further damage to the wounds, and in the meantime provide healing, minimize pain, control odor, and it should be easy to apply, low cost. But unfortunately, there is no ideal wound dressing, and there's no one dressing that fits all. Okay, so there are a lot of wound dressings, and if we go by the dressing types, there are alginates, foams, honey, hydrocolloids, hydrofibers, hydrogels, iodine, silicone dressings, charcoal, which have their own characteristics. And I have just, because these names may sound familiar, some of the available dressings, I would say these are the expensive ones, because they come under brands and there are various things. Some more: protease modulating matrix, which is quite expensive; silver, semi-permeable films. Lava is a wound dressing as well and helps in debridement; and negative pressure wound therapy, which is kind of a hot topic, already known to some of you, or maybe unknown to some. Okay, so how do you select a dressing? First of all, even though it sounds easy, it's honestly, I would say it's very difficult. I can just give a guide. We can start off with this, right? The basic is, what we need to achieve is the wound, we need to maintain ideal moisture. So that's one of the key things we have to focus on and control the infection. So if it's dry, hydrogels, hydrocolloids, we need to make wet. If it's exudating, if it's pouring out fluids, hydrocolloids, foams are going to absorb it, or else maybe even a negative pressure, a vac, which is commonly known as. If it's a deep space cavity, going into the foot or going into the thigh, wherever, even in the abdomen or anywhere, foams, negative pressures are effective. And if you need some antimicrobial action, so silver impregnated dressings are useful. Overall, we need to consider the cost as well. Sometimes we may be better off with something quite inexpensive like gauze, saline, acetic acid. They are also available options. Even though they do not come under these names, always remember these choices are there, especially in the community. Okay, so summarizing up: practical approach, good history and examination, decide the type of the wound, does it need debridement, does it need antibiotics. Debridement we have to do if there is a lot of slough, necrotic tissue impairing the healing. Antibiotics, each and every wound does not need antibiotics, especially if there is osteomyelitis, they need culture guided antibiotics. If it's causing systemic infection like sepsis, yes, needs IV antibiotics. There's no place for topical antibiotics. Do not put antibiotics onto the wound. There's no good quality evidence to show it's useful. And if there's no evidence of infection, don't start antibiotics. Then next thing is, does it need a specialized management and how to do a follow-up. So simple, practical approach. It's not like that practically when it comes, but these are the main things we have to guide our decisions on. So wound debridement, there are various ways of doing the debridement, but when it's a hugely large wound or wound with a pus, surgical option is the best, I would say. So debridement, our target is to achieve a viable, well-perfused margin, but it's not always possible, right? Especially if it's a ischemic ulcer, we can't achieve that, right? So what is important to keep in mind is, if we have to do a second debridement, always think whether we are missing something on this one. I'm not saying that everyone does not need a second debridement, but still it's good to run this question. When the patient is coming to theatre or coming to the general practice for a, and looks like he needs another debridement, always think, are we missing on something? Is there something we need to do? Okay, negative pressure wound therapy. So it looks like a fancy thing, expensive. Still, this is available in the government sector as well. So there are various machines. So basically what we do is, on the wound we apply these forms. It's like the commonly available RP form, but this is medical grade and there are some differences, and through this we apply these films and create a negative pressure to the wound. It has many benefits, as I said earlier. Stimulate granulation, microcirculation improved, exudate is controlled, edema is reduced, so ultimately resulting in a quick closure of the wound. So this is where the world is moving now. Even in Sri Lanka we are offering this to the patients, so we are lucky in a way. So the world has moved even further. So this is quite a new thing, still not available in our setup. It is a negative pressure wound therapy with instillation and dwell time. That is basically what this does is it applies the vacuum, and at times you can see there's a bag of solution. We can use various solutions. The machine itself sends some fluid through the tubes into the wound, and it irrigates the wound, and the fluid stays there for some time, and after that it's sucked out. So what happens is, at that time, whatever the local factors that are accumulating in the wound bed gets diluted, and then they come off with the suction. So it's proven that this further increases the or speeds up the wound healing than the negative pressure. But bear in mind, this negative pressure with instillation and dwell time all have their indications and contraindications. We can't apply this to each and every wound. We have to be selective, we have to consider the contraindications, and we have to decide on who needs this and who does not need this. Because on the other hand, we have to think about the cost as well, keeping aside all the indications and contraindications. Okay, larvae therapy. So still we are using the larvae. Many years back they used to come as a small packet and then apply to the wound and remain there and then remove. So this is medical grade larvae, blue bottle fly larvae. They come like tea bags. This is exactly what is available. On and off here in Sri Lanka also we can get access to these. They do a great job. They do a debridement and promote healing. So larvae is another option. And the best part, not the best part, the unfortunate part for the larvae is once they do their job, they die off. So they have a lifespan, so we don't have to kill them. Once they do their job, they die. And it's medical grade, virus, bacteria free. Hyperbaric oxygen therapy is available in Western countries, and I'm sure in Eastern countries as well. For very selected few patients, it's practice. And in addition, there are a whole lot of new things at experimental level, like ultrasound, special lights at different wavelengths. But overall, I would say there is no good quality evidence to say that it's going to be beneficial. So these are kind of the ones have a decent level of evidence and which is practiced all over the world. So the last bit, so how to improve patient outcomes. So first of all, we need to provide proper wound care, and don't forget the other aspects. Pain management. these patients have all sorts of psychological issues. At least we can talk to them. We can't fix all the problems. We can't correct their social issues, but at least we can have a kind word. We can empathize with them. That will be a relieving thing for them. And one of the important things is getting them back on their foot, early mobilization. And always respect the patient expectations. Sometimes there are patients, elderly patients who have extensive wounds, but they want to keep the leg. They may be dying in 1 or 2 years, so why bother them? So sometimes what they all need is some good palliative care, some decent wound care, and comfort the patient. Whereas there may be some young patients with extensive ulcers, even though it's technically possible to do something, they want to go for amputation, have a prosthesis, and get back to their life as soon as possible. So always respect the patient expectations. So that's why I'm saying sometimes we need to be patient oriented, and we need referrals, specialized care, and multiple disciplines involved. Okay, some common questions. I'm going to go through some questions before you ask me some questions. So hope I will cover at least some of them because of the time constraints. So wound ulcer, are they the same? I have already discussed about that. Antibiotics, topical, oral, IV. Okay, no topical antibiotics. Antiseptics, yes, sometimes, but not topical antibiotics. What to avoid in wound care? Gauze bandage. So gauze bandage is quite inexpensive, easily available, and personally we have seen a lot of patients coming with these gauze bandages wrapped around their upper limb, the hands, arms, legs, and unfortunately have seen some patients coming with this gauze bandage wrapped with the foot dead up to the level where the gauze bandage is. So it's not good. Do not use gauze bandage for in wound care. Go for some gauze, cotton, and crepe instead, because the crepe bandage, it's not fixed, it's elastic, so it can stretch, whereas gauze bandage, it's not going to stretch. It's going to be a tight constriction, cutting off the blood supply, perfusion. With the swelling of the wound, it's going to kill the foot, especially when it comes to foot or hand extremities. Compression, how many layers? All that matters is good quality compression. Even 2 layers is acceptable. This is especially with regard to the venous ulcers. Always make sure the patient has a pulse. If there is no pulse, then we have to assess the perfusion. It has to be at a specialized center, or I would say we vascular surgeons do that, and have to start on compression sometimes carefully, or we may have to revascularize the patient, as we told earlier. Okay, so another take home message: no gauze bandage for wounds in legs, hands. How frequently do you change the dressing? The most important question is when to change. If it's soaked through, it needs a wound inspection. If the patient is having swelling, pain, fever, yes, it needs an inspection. Should we just keep on wound dressings, or should we consider closing the wound with a skin graft or a flap? That depends on many factors. We have to consider the patient's comorbidities, the size of the wound, how soon we need to close this wound. So it's another discussion for about at least a half an hour. So yes, we can go for some wound closures, but only in few patients, only in some patients. Amputation, does it mean we have failed completely? Not really. Sometimes amputation is far better than prolonged wound care, especially in a young patient. But we need to make sure that it's the right choice. We have to have a discussion with the patient. We have to explain what we can offer, what we can do, and the realistic time limits, everything. So amputation, I would say we keep it as the last option, and most of the time we are able to get off without amputation. Okay, what do you think about this? Should we go for amputation? this is how this patient present. This is a 72-year-old lady. She was mobilizing by herself, diabetic, heart failure, but having a decent quality of life. Extensive wound almost near the ankle joint. So this is what we have personally done. We have revascularized this patient, done the bypasses, revascularized, because even though she was having heart failure, she's quite well. The fitness wise, everything, she was good and relatively independent, and she wanted the leg, she wanted to walk. She's not going to die in a 1 year or 2 years. So this is at some point after about a couple of months we have achieved wound closure, a little bit of small wound, and this is about maybe 7-8 months back. Now she's walking, she's doing day-to-day activities, independent, not relying on the family, not relying on her daughter, and the daughter can go back to the work. So it's a huge thing. If we did amputation in her, she's going to be wheelchair bound or rather bed bound. Daughter loses her job, somebody has to take care. There's a huge cost. So even this we can salvage, but they need to come at proper time, they need to be detected, and they need to have whatever the specialized management that is needed. So that's it. Questions and answers.
Thank you, sir, so much for that descriptive lecture, sir. I appreciate how you took your time to tailor the lecture for the needs of medical officers, and I'm sure everyone is intrigued to persuade you to arrange a wound care workshop as well. And we, as the GMA Academic Subcommittee, would be honored to lay the groundwork for that.
Thank you.
In the meantime, sir, let's go for the Q&A session.
Yeah.
So the first question is, what is the role of hypersaline in deep wounds and how to prepare it?
Okay, so yes, this is hypertonic saline, I believe, 3% saline.
Yes, sir.
Yeah. So hypertonic saline we can use as a rotational dressing, especially if it's like infected wounds, pseudomonas infections, ongoing colonizations, we can use.
Right. Then, sir, okay, I think you have already answered this, but what's the role of antibiotics in such scenarios? I mean,
I think we covered the
yes,
antibiotics,
sir,
unless it's infected or evidence of deep infection, osteomyelitis, cellulitis going on, surrounding infections. No.
Similar questions are, what wounds will need topical antibiotics, normal saline, idosol, intrasite gel, and hypertonic saline?
Well, that's a lot of brand names, right? So we went through the dressings. So the principle, I would say the principle, it's important to get the concept, right?
Yes, sir.
It's not about saying this wound needs idosol or something like that, all right? So going back to the question is asking about
what wounds will need topical antibiotics, normal saline, idosol, intrasite gel, and hypertonic saline. So how to choose?
Yes, I would reframe that question, right? So he or she is asking about the topical antibiotics. Yes. So first of all, we need to identify why you are thinking you need antibiotics. If it's infection, yes, obviously. If it's sepsis, yes. If it's surrounding cellulitis, yes. Right. But I think this is when you have a doubt, when there's a biofilm, right? Whether to go for some antiseptics or something like that. Yes. So the biofilm, the best method to remove it would not be the antibiotics or rather the antiseptics. It would be a gentle debridement. Supported by something like some dressing with antibacterial properties, silver or some iodine or some iron preparations. I'm not going for the brand names. And even acetic acid is good for them.
And the other question is, once CND is done, how to decide when to open the wound or redressing?
Well, so that's a good question.
Yes.
That depends on the patient. let's say you do a wound and in a patient who is quite septic and you are quite concerned about the wound, let's say it's a necrotizing fasciitis and you don't know what's going on. You do it today morning and by tomorrow still the patient is having gross fever spikes and he's in pain, systemically unwell. In that case, next day morning, yes, it's worthwhile to have a look. But let's say you do a wound and wound debridement and then you see the patient next day, it's quite well, then 48 hours after a regular wound debridement is fair enough as a routine. But this person is asking about cleaning and dressing, right? So cleaning and dressing means that depends on the factors I told earlier. So when the dressing is soaked, if it's having pain, discharge, erythema, then you need. Sometimes we can keep them for about 3-4 days. Sometimes we can keep them for 1 week. It's individualized. So it's difficult to give a straight cut off. I hope that covered debridement and CND both.
Yes. And the other question is, this comes, I think, from the PP aspect. 1 week old wound with whitish slough comes to the primary care unit. So how to approach such cases?
So
around 1 week old, or at least 1, 2, 3 days old wound.
Yeah.
Patient is coming to the
with a slough.
With slough.
Yeah.
And how to approach such wound.
Yes. So then you have to go through the whole thing. Assess the wound, history examination, whether whether it fits into a certain type of wound, diabetic foot wound or this ischemic wound, and what type it is. If there is gross pus, it needs urgent attention. If there is no evidence of infection, vascularity is perfect, no precipitating factors, everything corrected, then you can attend to the slough and then see how things go. Right? But need to keep an eye because this is the first visit. You don't know where this wound is heading. So maybe another close follow-up in about 2 days is where you can actually make a decision whether this is safe or this needs urgent. This is provided the patient has a pulse and there's no doubt about it.
What is the antibiotic of choice for infected wounds?
That's a very broad question, isn't it? Yes. Well, most of the time it's depend on the local antibiotic policies, the hospital policies, but unfortunately we don't usually have a hospital policy. We have a national antimicrobial guideline. You can follow that, right? And usually what is practiced all over the world, backed by the evidence, is usually the diabetic foot ulcers are the most important ones when it comes to antibiotics because it's the one that's spreading rapidly and that needs antibiotics. So usually first line antibiotics, most of them have had some antibiotics before they present. So we have to go for some second line like piperacillin tazobactam or something like that. And it's most important to cover the specific pathogen. So always start with some empirical, and once the cultures are available,
you can cover this.
Yeah.
And for wound healing, apart from for wound healing, apart from high protein diet, what else do we have to give? Zinc, vitamin C, etc.
Yes. Well, we are talking about the nutritional deficiencies. When it comes to general population, the ones with the nutritional deficiencies, one thing is it's quite difficult to narrow down this is the cause for this wound to go down, right? So they may have deficiencies in vitamin C, zinc, selenium. Those are things that cause nutritional deficiencies that leads to prolonged wounds, right? So, but it's the ideal way is we can check for the selenium levels and things, but it's not going to be practical and quite expensive. So I would say a general well-balanced diet is all you need with adequate calories and adequate proteins to start off with. But if you still think there's a problem with the diet, always go for the some support from the nutritional specialty,
Yes, sir.
because we have now nutritional specialties all over the country, so they are the best person because they can look into their diets
Optimize that.
if they think they can do the levels as well and see what is needed. But before going to that part, we have to correct all the easily correctable and screenable things.
Right. So another question, sir. Using gauze bandage after the wound toilet in a necrotizing fasciitis patient, is it recommended or not?
I would say no. Simply answered that.
Yes.
Because necrotizing fasciitis, whatever, it's going to swell up, edema, constriction, microcapillaries, and everything going to get compressed. So always go for gauze. I'm just telling the easily available and the low cost ones. Gauze, and then cotton, and then crepe bandage.
Right.
Do not use gauze bandage.
Is there a place for silver sulfadiazine for pressure ulcers?
Yes, there is a place.
Simply answered. Yes,
That is
yeah.
mainly to protect the skin area, because they have some exudate and the surrounding skin. Silver sulfadiazine, even for the wound itself, sometimes you can use, and zinc oxides protect the skin. Those things can be used. But need some supervision, and because if you use silver sulfadiazine, it will stain the clothes,
Right.
blackish color. So those things also we have to consider, and how to apply. You have to be very not to be let it to the attendant to do it.
Yes.
You have to have an eye on it.
I think that's it. Okay.
Another
Another question. Is there a place for tropical use of IV gentamicin?
No. There is no evidence, no good quality evidence to say topical antibiotics are effective for wounds. There is no good quality evidence.
Right.
I mean, I'm talking about these chronic wounds, right?
So thank you again, sir, and happy to have you again with another such interesting lecture. We shall conclude today's session. Thank you.
Thank you.